Good evening. Well, I guess good afternoon or good evening, class, depending on what time zone you're in. We're going to spend a few minutes today talking about economic drivers that can, I guess, I hate to say produce, that can result in ethical dilemmas, either for patients or the consumers of healthcare services, the payers, mostly health plans or public agencies, providers, those generating healthcare goods and services, and our old friends in public policy. So um, hopefully that as we've kind of walked through this, we started out with Errol's article, and he was talking about, here's is the situation in early 1960, and it drove some changes, especially in government programs based on healthcare. Then we talked about just in general business ethics, and then tried to illustrate how business ethics uh, transcends into healthcare ethics. And then last time we talked about healthcare, medical, clinical ethics, pick your nomenclature, whatever you want to call it, and outlined the potential ethical dilemmas that certain subsets of I'll call them actors, certain subsets of actors that are functioning within the healthcare marketplace. And then tonight we're gonna move into the 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 economic factors or the economic drivers that could set up a situation where there are ethical dilemmas um, that these actors in the healthcare environment have to determine how they're going from a moral compass or ethical perspective, how they're going to function and operate. And I think that this is one thing that over the years, as I've either taught class or managed individuals in a healthcare marketplace, it's a weak link because they either didn't have the background in, especially microeconomics, or when they were taking those micro classes, they didn't pay any attention at all. It was just a class they had to take. They took the class, got a grade, moved on to the next one. But it's kind of the foundation, the underpinning, and if you can get your arms around just some of the basic concepts, it'll make some of these next modules, it'll clarify the way we're moving into the modules, because after this we're going to start talking about codes that providers use. We're going to talk about the claim forms. We're going to talk about issues with data repositories, talk about payment integrity just in general, which is kind of the watchdog on the health plan side to ensure that claims are processed accurately every time they come through the system. And just to give a little background, healthcare expenditures, and I found this information out on the internet, and it is a end of 2022. So I haven't been able to find any information on 2023 as far as healthcare expenditures. And unfortunately, the way these estimates are calculated and information put out there, sometimes there is a significant lag time. So healthcare expenditures have increased from 74.1 billion in 1970 to 4.5 trillion in 2022. You think about that it's gone from 74 billion to 4.5 trillion. And granted, it's 52 years, but still, that's significant increases. And if you're in the literature, reading literature, listening to talking heads on TV, if you go to work at a health plan, especially at a health plan, you'll hear the actuaries talk about, we've got to, here's our healthcare trend it's been trending upward at 2%, 3%. We've got to bend that curve. We've got to bend that healthcare trend and bring it down. We can't continue to function with that healthcare trend going up like that. And this is what they're talking about. It's healthcare expenditures, and these healthcare expenditures are what has everybody in the United States at least concerned about just the cost of healthcare, just the impact on GDP on healthcare. So if you want to look at it from a percentage basis, healthcare expenditures increased 4.1% just from 21 to 22. That's before inflation bounced out of control. When inflation's setting down here at, I don't know, it was setting 0.5%, 1%, until, Biden came into office and things have kind of gone south since what he came in 2020, I guess. So things have gone kind of south from an inflation perspective. But before that, with these low numbers of inflation, you had healthcare expenditures significantly outpacing just the price inflation of all other goods and commodities. And, it was a concern then, and it's definitely a concern now. And according to the information, again, I found out on the internet, waste and abuse in the healthcare arena accounts for approximately 25% of the total healthcare expenditures. So the number at the end of 2022 was $4.5 trillion. If 25% of that is due to waste and abuse in the healthcare arena or in the healthcare marketplace, then you're talking about north of $1 trillion that was allocated to goods and services, or allocated to bad actors who were functioning in the healthcare arena, and that one little something north of one trillion was all due to waste and abuse. And when I talk about waste, you think about duplication of services. Go to see my primary care doc, and if he has an X-ray machine in there, he may take, and let's say I've got a bad back. I go to see my doctor, and he said, well, let's take X-ray. Take an X-ray, and he can't tell anything X-ray. So he said, well, I'm going to send you out to the imaging center with the hospital, and they're going to take another film. And so I go to the imaging center, and I say, well, the dude took an X-ray, and he wants me to take, an MRI, a CAT scan, or whatever. And so I'm out taking it, and it doesn't give any clearer picture. So now I'm duplicating efforts and still not getting any results. You see the same thing with lab work. Usually a lot of these duplicative services are in the diagnostic services, radiology, laboratory work. You're going out and getting lab work, you feel like a pin cushion there, drawing blood, playing around. And again, a lot of times it's waste. It's waste. And when I think I gave the example in one of the previous modules about individuals, especially on the pharmaceutical side, will continue to go in and pick up their prescriptions, whether they need it or not. They may not, some of them are going out and selling it on the black market, especially when you're talking about painkillers and some of the behavioral health type drugs. But even if it's not, if you don't need it, why go pick it up? You have people just stockpiling, and again, that's waste. And when we talk about abuse, that's where we talk about abusive billing practices by healthcare providers. We're talking about abusive decisions that patients are making, especially when it comes to motor vehicle accidents and workers' comp and subrogatable type services or goods and services. So there's just a lot of waste and abuse. 25%, you're talking about $1 trillion. That's a lot of waste and abuse. And it is estimated that 7 to 10% of that 25%, or let's say 7 to 10% of total healthcare expenditures, may be due to fraudulent activities. When I'm talking about fraudulent activities, I'm talking about providers that are sending claims in for goods and services that they didn't provide to anybody. Goods and services, or they are fraudulently taking and playing around with the claims payment system in such a way that it's going to increase the revenue that they receive for those particular services, whether they provided them or not. So 25% of that $1 trillion, of that $4.5 trillion waste and abuse, of that $4.5 trillion, 7 to 10% of that $4.5 trillion can actually be fraudulent activities. Ethical issues are impacting the decisions by employer groups, employees, and patients. payers, and typically payers outside of the government realm are going to be health plans, public policy, and providers in pursuit of the production, either the pursuit of healthcare goods and services or the production of healthcare goods and services. And lastly, one thing that talked about HIPAA last time, but one thing most people don't stop to think about is it's not really included in this 4.5 trillion, I don't think. It's just the cost to society when there are data breaches. Data breach on a provider side, data breach on the policy side, data breach on the health plan side. Somebody steals the data, then what's going to happen? They can sell the data. They can take that information, especially if it's got your social security number, name and birthday. You have Yahoo's going into opening new bank accounts, opening new credit cards. Then just the cost of mitigating that. That hadn't been too long ago. I can't remember whether it was Target or Walmart or somebody sent me a letter that said, unfortunately, your data's been breached, and and to help you take care of that, not only do you need to call your bank and let them know, but we're going to provide you access for 2 years to one of the, I can't remember which one of them, but one of those outfits that helps to take care of stolen information or stolen data. I mean, I use TurboTax to do my taxes, and part of the product that I buy from TurboTax is one of their little products. It helps keep an eye on if anybody is trying to steal my information or trying to do something nefarious when it comes to my financial dealings. So data breaches are a huge issue, and that's why, especially in health plans, we spend a lot of time in health plans doing HIPAA training, making sure everybody understands what to do with data to keep the data breaches from happening. And kind of to tie into this, we're going to talk just a few minutes at the kind of the tail end of this segment here, talk about microeconomic factors, microeconomic concepts, and how that ties into the potential issues with healthcare ethics. I'm almost certain I talked about it in one of the earlier modules, but just think about it. Go back to your old microeconomics classes. Economics, social science, like anthropology, social work, psychology, a lot of social sciences out there that study choice. What differentiates economics from the other social sciences is, there's basically 3 pillars of thought. Economists talk about opportunity cost, talk about self-interest and optimization, and talk about decisions made at the margin. You can remember, if you took an econ class, or if you paid any attention at all, when you're in class, you'll remember your econ professor, trying to drive that home for you so that you understood exactly what they were talking about. And also, when we talk about theory of the firm and talk about profit maximization, again, it comes back to self-interest. That's one of the pillars, profit maximization. And again, I'll be the first to tell you that companies are in business for one reason and one reason only, and that's to make a profit. I don't care what anybody tells you. That's why they're in business. And when you look at total revenues are going to be what? Prices times units. If I'm thinking about patients, they work for an employer group, their prices times units, that's what they're paid. They may not be a price times unit type job, like a union job where you're punching an hourly clock, but even if you're salaried, it's still prices times units. You get a salary for each year. That salary is your price, and that year is your unit. If you're thinking about health plans, their revenue is driven by number of contracts or number of benefit plans that they sell employer groups times whatever the premium price is or whatever the financial arrangement is, and that becomes the price. So it's benefit plans or contracts that they sell employer groups, and the price is the premium that they charge. Now, when it comes to selling those contracts to employer groups, there's a couple of ways to look at it. Most health plans will look at it as, I'm going to sell a contract to the employer group. So John Smith is a school teacher in your local school district. John Smith is to the health plan, John Smith is the contract. Now, John Smith, based on how John decides to work that contract, most employer groups will have options. As an employee, you can have insurance just for yourself. You can have insurance for yourself and spouse, partner, whatever terminology you want to use, or you can have insurance for yourself and your families. Now, when I worked at Blue Cross Blue Shield, it was, I could have insurance for myself, I could have insurance for my family. I didn't have that option, insurance and partner. That wasn't an option available. And so a lot of us, and my son is too old to be covered under my health plan now. So a lot of us felt like we were subsidizing those individuals with large families. But be that as it may, you go to the employer group, you sell the contract. The contract is for the employee that works at that employer group. And then they talk about covered lives. So if it's John Smith and say his wife, tied to that contract, there are 2 covered lives. If it's John Smith, his wife, and 3 kids, there are 5 covered lives tied to that contract. So depends on how they sell it. That's how you're going to determine and you're selling it on the contract. But when it comes to doing the analytical work in a health plan, you're talking about covered lives. When health plans talk about membership, they don't talk about contracts. They talk about covered lives. 500,000 covered lives, 1 million covered lives. If you're an outfit like United or Aetna or Cigna, or even in the blue side, if you're Anthem in the blue side, you're talking about millions of covered lives. So we've kind of talked about the patients, we've talked about the health plan, and now we're going to talk about the providers when it comes to revenue. And providers drive their revenue. It's either what's called fee for service, and it's price times the number of units that they generate. So an office visit's a unit. If they do radiology work, it's a unit. If they do some lab work for you, it's a unit. Different types of units. Or they can have what they call value-based contracting, where they get a set fee for each covered life or each covered life that's assigned to them on a monthly basis. But for this exercise, we're going to talk about just the fee for service. So fee for service is based on volume. It's not only based on volume, but it's based on the type of service that you provide. And so what happens, and where the dilemma comes, especially on the provider side, the ethical dilemma is their contracts are negotiated typically on an annual basis. There are some contracts that they talk about an evergreen contract, and that means a contract that just keeps rolling over year after year. I've seen some contracts for provider groups that they're negotiated every year on an annual basis. I've seen some that are 3-year contracts. I've seen some 5-year contracts. If they're 3-year contracts, there's typically what they call an escalator clause built in. Could be tied to the consumer price index, could be tied to the CPE, a lot of indexes that you can tie to. And basically it says in year 1, the base for an office visit, we'll call it just a medium value office visit, let's say $60. And if it's tied to the CPI, the next year it'll be $60 times 1 plus the CPI. And then the next year, again, 1 plus the CPI. And what happens with providers, because it is negotiated on the annual basis, and you think about being a provider and just the cost of maintaining that practice in 2021, well, 2022, 2023, 2022 and 2023 especially, with inflation just blowing through the ceiling. And if they had that contract in place prior to, let's say they negotiated the contract in 2020 before inflation just went crazy, and it's tied to, you know, this, with that contract, that's the base contract, and if depending on how that works, if their escalator clauses aren't keeping up with inflation, then it puts them at a disadvantage. And it's only that new rate only kicks in on the 1st of January every year. So if they got caught short in, say, 2021 and 2022, when they weren't meeting they weren't keeping pace with the inflation of, the supplies and the labor and everything that's involved in their practice, they were at a significant financial disadvantage. And so they've got two choices. They can either bite the bullet and continue to move forward, or they can decide to go that, now we're getting into this ethical issue, this ethical dilemma. They can talk about what's considered upcoding. And basically what happens when they're upcoding is a 99213 is and you'll get into that on the codes later on, but a 99213 is a CPT code for a medium office visit. A 99214 is a higher level, and a 99215 is the highest level, and that evaluation and management type office visits. And if I'm a provider and I'm sitting there and I know that the rate that I'm negotiated for that 99213 is $60, but I've negotiated a rate of $100 for a 99214, and I've negotiated a rate of $150 for a 99215, then it becomes an ethical, now my moral compass is starting to flutter a little. My moral compass is trying to figure out what I should do. I'm in an ethical dilemma because all I need to do is kind of tweak a few things, kind of add some stuff to the chart, maybe kind of play around with the system. And now all of a sudden, my distribution of office visits, rather than being kind of a normal distribution, now all of a sudden it's starting to skew toward that 99214, 99215 situation. So that's what we call upcoding, and that is an ethical dilemma. Now we're talking about upcoding. Now we're talking about going back to that 7 to 10% of healthcare expenditures being tied back to fraud type activities, or could be tied back to the 25% of abusive activities. Kind of a fine line between abuse when it comes to billing and blatant fraud. So blatant fraud is a little harder to prove. Abusive billing's not. You can go in and it's fairly easy to prove to generate the information that signifies abusive billing. It's a little harder to generate that information that's going to actually be considered fraud. And when we're talking about fraud, now we're talking about it's not just a civil issue, it's a criminal offense. So that's where we're running to when it comes to on the revenue side, when it comes to providers. So think about the revenue, and then let's drop down and let's think about costs, because the revenue that a health plan pays to the provider is actually the cost of the health plan. So if the health plan can squeeze that cost, and as they squeeze the cost, it's going to squeeze the cost going, or the revenue going to the provider. It's going to put the provider in a more difficult situation. Just kind of as a side note, if you ever work in a health plan and you ever work in network management, or if you're working in a provider group and you're doing the contract negotiating, just always remember the negotiation range is set by the payer and it's set by the provider based on information that both entities have. Your payer is going to set the price ceiling of that negotiation range. The payer knows here's the maximum I'm going to pay, and I'm not going to pay any more than that. The provider sets the price floor, and the provider sitting there and saying, here's my bottom line, and I'm not going any lower than that. And so the provider and the payer have set that negotiation range. Think of the provider as setting a price floor. And again, if you go back to your micro classes, a price floor, you can't legally, if a price floor is set, you can't legally go below that price floor. We're not talking about legal issues here, but it's the same concept. So a price floor, and in the economic marketplace today, think of minimum wage. Minimum wage is a price floor. Providers setting that price floor. The payers are setting the price ceiling. They don't want to go above a price ceiling. Think of rent controls. If you ever lived in an area with a rent controls are in place. You're not supposed to go legally above that price when you're setting rent payments. So think about those. So in that, because it's the revenue on the provider side and the cost on the health plan side or the payer side is what we're seeing now. And I've actually got a video loaded out there when we talk about the struggle over the financial coin. There's a financial coin in healthcare. On one side of that financial coin, you've got the providers. The other side of the financial coin, you've got the payer. And both sides are trying to struggle to maximize the most of that financial coin that they can get. Make sense? Struggle over that financial coin. One other thing to think about is when we talk about accounting, let's go back and let's talk about the total cost. So providers have a total cost. They've got fixed costs, they've got variable costs. Fixed costs, buildings, capital, equipment, bricks and mortar usually. Variable cost typically is going to be your labor. Salaries you have to pay providers, salaries to pay the nurses, salaries to pay the billing office, salaries to pay, the front desk, salaries to pay the people that take your blood pressure and things. On the health plan side, again, you've got fixed and variable costs. Both sides are trying to minimize those costs. Again, it goes back to self-interest, trying to minimize those costs. And the health plan, same situation. They've got fixed costs and they've got variable costs. When it comes, you'll hear people talk about, especially in the healthcare literature, they'll talk about two types of profits: accounting profits, economic profits. Accounting profits are just basically total revenues minus total cost. Again, fixed cost and variable cost get your total cost. But on the accounting side, it's the total revenue minus explicit cost. And when I say explicit cost, they're talking about the cost that generates a payment. An invoice comes in, you have to write a check or pay by credit card or whatever for that supply, for that good or service. So providers are paying for, paper and all kinds of office supplies. And as those invoices are coming in, they're having to make salary most of them every 2 weeks. So invoices are coming in, checks are going out, those are explicit costs. Economic profits, it's total revenue minus explicit cost, but also minus implicit cost. And implicit cost goes back to the opportunity cost. I'm a provider. Let's say I'm a sole practitioner. Got my own shop. My wife does my bookkeeping for me. I'm out in the middle of, I'm out in East Tennessee somewhere. I may not hardly be to the Smokies, but I'm getting close. So I'm kind of out, not really in Appalachia yet, but getting there. But I've got a sole community, and I'm a primary care doctor. I'm doing, got my office. And so when it talks about economic cost and opportunity cost, at some point, and hopefully they're doing it multiple times in a year, I have to decide from a financial perspective what's best for me. Would I be better off from an opportunity cost perspective closing my office and going to work for a medical group, going to work for a medical group and working almost just become a salary doc for the medical group? That's what we're talking about, opportunity cost. So, and its opportunity is the same as implicit cost, and implicit cost is the thing that separates accounting profits from economic profits. When we're talking about, and we'll go back to the patient, one more time, when we're talking about, again, their revenue, they're hourly employees, they're, paid a salary, but that is their gross revenue. Their net revenue is what they take home in their paycheck. By the time, it's not so bad in Tennessee, but by the time Uncle Sam sucks you dry on, federal income taxes, Social Security, Medicare, you've got the states, most states sucking you dry on state income taxes. You're paying workers' comp premiums out in most states. So at the end of the day, that's your disposable income. And if you're a patient and you've got a limited disposable income, and especially now where your real disposable income has been deteriorating over time, you're having to make a decision when it comes to healthcare goods and services. You're having to make a decision when your employer comes to you and says, okay, here's your options. And with each of these options, you've got a certain premium you're going to pay. Or they may come to you and they say, okay, here's the premium for, if you want to go for a high deductible plan, or if you want to go for a high co-insurance, or you want to go for a high, copay. And now we're talking about, liability issues. You're talking about the liability issue that you as a patient have when you're going to buy that contract that the health plan is sold to your employer group. And it's now you're driving your healthcare premiums. And you're also concerned as a patient, you're concerned about access to care. So now here's your ethical dilemma. You got your disposable income that's been deteriorating. You've got healthcare premiums that you got to keep paying because your employer is taking it out of your paycheck. And you've got concerns about not only access to care, but the quality of care. And so now you're in, as a patient, you're in a somewhat of an ethical situation where you're trying to make a determination on how your moral compass is going to twiddle as you're trying to make decisions. Do you continue to pick up those pharmaceuticals that you're not going to need, but you're going to say, hey, I've already paid my healthcare premium. You're talking about self-interest. I'm going to optimize my access to healthcare, and I'm going to grab all of those pharmaceuticals. Or you say, I've got a $5 copay, or I may have a zero. Or you've got a zero copay, which there are some health plans out there, especially you get to be an old guy. There's a bunch in the Medicare Advantage field that you can get zero copays. At that point, it doesn't cost you anything. And most old guys aren't working anyway, so they got plenty of time on their hands. And so there's no copay. All that it's going to cost you to go to the doctor is the transportation to get there. And if you drive, you can do Uber, you can do Lyft, you may drive yourself, and you may have some parking. God, if you're here in Atlanta, you're going to have a parking fee to go to the doctor. And it's the time you spend. And if you're retired, what's the value of your time? It may be pretty low. So you find yourself going to the doctor more and more. Hey, some retirees actually look at it as a social engagement. When I worked at one of my previous health plans, we had a contract with the government. We had one with DOD, and we had one with VA where we set up doc in the box. set up clinics, primary care clinics, especially for the VA. You'd set those primary care clinics up, and you had these retirees. It was a social event. We made the. I'm not going to say we made a decision that in the dog in the box we had coffee, free coffee. It was an incentive to get them to come in, or we thought it was going to be an incentive to get them to come in to ensure that we help them optimize their healthcare status. Again, remember, that's why you have the healthcare system, to optimize that health status and to minimize the deterioration from it. So we thought, yeah, it'd be a good idea. Have free coffee. I think there was maybe on Fridays, maybe we had some like donuts or something. I don't remember, and I don't want to say it backfired, but you started having these guys come in, and it was just like, hey, veterans, they swapping war stories and drinking coffee and hanging it. Had TV. They were watching. I don't know what kind of shows you watch during the day, but then it turned out to be a social event. So that's where you're going to have ethical dilemmas driven by economic factors, whether you're in the patient side of this healthcare arena, the payer side and the health plan side, or the provider side. These are the kind of decisions, especially on the patient side, that disposable income, that real disposable income, as it's being deteriorated by inflation, are going to drive a lot of decisions. And then lastly, if you're talking about the policymakers, our buddies in DC, that, or maybe even our buddies in the state legislature, that they are normative kind of individuals. They say, well, you're only consumers. You don't know what's good for you. Here's the way things should be. Remember, normative statements. Here's the way things should be, or here's the way things ought to be. And they're making decisions. They're putting policies in place, and these policies that they're putting in place are impacting resource allocation. They're impacting the distribution of services, and they're impacting socioeconomic issues. So their attack, and again, governments come in and try to dictate strategies when they perceive market failures. And so if they perceive a market failure with respect to socioeconomic issues, they're going to try to redistribute some wealth. They're going to try to improve access to healthcare goods and services. And as they improve access to healthcare goods and services, what does it do for the rest of us? It puts a drain on resource allocation, and it puts a drain on the distribution and access to those healthcare goods and services. Just look at what, and I don't remember the numbers, since 2020, there's been 10 million people come in over the southern border, whatever, I don't know, whatever that number is. But think of it, if let's say it is 10 million people that have come in over the southern border. What do you think that's doing with respect to access to healthcare goods and services? What do you think that's doing with, as far as resource allocation and distribution of services? I mean, it is blowing up. The last time I tried to get in to see my primary care doc, I called him on a Monday morning, and then I had some issues. I had some chemical issues with some putting some insulation, some of that foam insulation, an attic, and it was bothering my hands, and I need to see him. And I called him, and he said, well, the secretary said, well, if we're lucky, I can squeeze you in Friday. I'm thinking, Friday? What is the matter with you? She said, oh, but you can go to urgent care. Of course, they like for you to go to urgent care. They don't stop to think that for me to go to urgent care, it's $25 copay. If I go to see my primary care doc, it's $0 copay. So it's going to cost me an extra $25 to go to urgent care. But if I'm looking at access to care and I need something done on the money, and it's not going to be able to see my primary care doc on the Friday, then there is an issue with access to care. And I think I'm going to stop right there. We're going to see, we're we're going to come back and we're going to start to go through these, I guess, ethical decisions or ethical issues, and we'll get a little more into detail and kind of on the payer side, the health plan side, the provider side. And I think I've got a slide in here where we're going to talk about public policy too. So, talk to everybody in a few minutes.